Welcome to All Home Care Matters, the show where we discuss all things home care, with discussions on important age-related matters and topics. Brought to you by Enriched Life Home Care Services, the #1 rated home care provider in Michigan by Top Rated Local.
Hello, and welcome back to All Home Care Matters. If this is your first time visiting us here at the show, we want to say thank you for taking time out to be with us today. We appreciate how valuable everyone's time is, and that's why we try and make each episode here at All Home Care Matters something that will hopefully matter to you. Today, we're honored to welcome Andrew Karesa. He is the president and CEO of blueBell Village. Welcome, Andrew. How are you today?
I'm good. Thank you. Thanks, Lance, for having me.
Oh, it's our pleasure. We always love working with our friends north of us in Canada, where you're at. Is it okay if I call you Andy?
Yeah, absolutely. That's what most people call me, other than my mother.
Okay. I can understand and appreciate that. So, Andy, why don't we just start off first? I want to have you kind of describe what blueBell Village is all about and a little bit about your background before we get into the questions for our viewers and listeners.
Sure. So let's start with what blueBell Village is all about, because I think that's ultimately the most important thing. blueBell Village is a company and a movement that I created. Initially, it wasn't to support people with dementia on a broader lens. Initially, it was just to support my grandmother as she was going through Alzheimer's. I really noticed that the people around her and the people we were trying to get to support her were doing the best they can, but there were limitations. And I started saying we need to do something different. We're called blueBell Village because the initial idea was let's build a dementia village. As we all know, the world went crazy in 2020 and 2021, and the process of creating it became unsustainable reasonably quickly. So we ended up shifting to this thing we talk about kind of later called blueBell Connect. But really, blueBell Village was the idea of how do we give people living with dementia the autonomy and the ability to do what they would normally do. Our slogan is restoring the personhood and independence of those living with dementia. And that's ultimately what's important to me, is the idea of this person has dementia, but why, when they get this diagnosis, does their world have to change radically? Why do we have to then put up these barricades and say, this is how we have to care for you now? And yesterday I was caring for you differently. And so that's ultimately kind of what blueBell Village was created by, this movement of let's allow people that have dementia to be cared for as they need. Going into me a little bit, I never wanted to have anything to do with health, which is kind of funny that I ended up in this space. A lot of people, we end up where we end up. The Lord will guide our steps. And I ended up here because I knew my grandmother needed help. So that's kind of what started. So I'm a practicing engineer. I worked in the oil and gas industry in Alberta for many years. And tail end of that, my grandmother's kind of Alzheimer's diagnosis started ramping up, and the care needs of her started really increasing. And I said that I'm going to try and make these things to support my family. It wasn't the idea of I'm going to make a company around this thing. It was I'm going to make this tool and these supports that my family and the hired care team that we have can utilize to support my grandmother. So really, that's kind of what it started as. As an engineer, I like problems. I like trying to come to solutions. And the solution was, how do I care for my grandmother? How do I make sure the people that are caring for her do it properly? For example, an engineer, like, I want answers to everything that are black and white, but I am not clinical in nature. Right. And so how do I care for my grandmother when I need to look after her? And I don't understand the specific triggers that Alzheimer's may have versus if she had frontal temporal or something. What triggers do I need to be aware of? What things do I need to do that work, and what things cause agitations? Because I would see sometimes we had home care workers would come in and look after my grandmother, and they were doing the best that they could. And I'd say, how do you know that this is what you do for my grandmother? why are you doing this? Why is this the right solution? They go, I don't know. It's just what we've done before. And I'm like, why is this what we've done before? That's pretty scary when you can't articulate to me the reason why you're doing what you're doing. You're just doing it because you did it before. So I started building this tool to just kind of help my family. Like, okay, well, these are the things that they're doing. These are the things that I'm doing. This thing is my sister is doing. How do we all make sure we do the same appropriate things to give my grandmother continuity?
Right.
And so that was kind of the starting point of blueBell Village.
Yeah. And it's spoken like a true engineer too. Why does it work this way, and why do you do it this way? Which I'm sure really served you well at that time, right? I mean, so many times I think, especially, because I have been in healthcare for like 20 plus years now, Andy, and patients and families, they just sometimes to their detriment just go along with whatever is said or whatever is done without knowing the reason why behind it. And I think it's important for people to understand that. But I want to talk about a little bit about the name blueBell Village, which does carry some significant meaning. Can you share the story behind it and what it symbolizes for you and your vision?
Yeah. So as I mentioned before, blueBell was created for my grandmother. It was created as a way to support my grandmother. And I didn't want to necessarily make this into a company at first, but I wanted to create something to look after my grandmother. And then as we started to build out where other people can use it, the idea is what makes most sense in a name. So the blueBell is the important piece in that. And so my grandmother's name was Shirley Bell.
Okay.
Her favorite color was blue, and her favorite thing to do in this world was always garden and look after flowers, grow things and vegetables, and be out there picking weeds. And no matter what it was, all of her life, that was what she did. I mean, we would, as kids, go to her house and start picking weeds. And I remember when she was, I think it was like her 70th birthday, she was having a hard time getting up and down. So my parents got her this, maybe parents, my aunt, maybe. She got this little wheeler weeding machine that you can like sit on and go across the garden rows, and you can sit on it. She's got little tools on the side, and she can pick weeds. But she got to keep doing what she wanted to do. We just gave her the tools to support her. And really, as I was thinking, what can I do to support my grandmother? I thought the name blueBell really resonated because of it was for my grandmother, and the company is for my grandmother. And for that reason, if you kind of look at the way it's written out, blue is in the first B in the blue part is lowercase, and then the B from the bell is capital, because what's really important in that is the bell part, which is my grandmother, because she was the center of the organization. And that's really what it came down to for me, was making it for her. And there's something that some people in this community talk about, and it's terminal lucidity. So it's this really weird phenomena where someone's at the end of their life, they have a dementia, and then for whatever reason, they start regaining some of that cognitive functioning. And for months, years before, they couldn't process, they couldn't remember these sort of things. But for some reason, it all comes back to them, hits them like a big wave. And this happened to my grandmother. And I remember I was out in the middle of the woods, just doing target practice with my gun. And then I get a call, come see grandma. She's not doing well. This is going on. I go, okay. So I pack up, I drive through the mud and get out of there. And I go see grandma, and we start talking, and then she had no processing of what I did for many years before this. And then I start talking to her about this, and as she was going through terminal lucidity, she actually recognized and processed of what I was doing, and the fact that I built this thing for her. I named it after her. That was like, you were the guinea pig for this whole thing as I was building it and testing it. And it really resonated for her, because we could connect on the fact that her story didn't end when she died. her story transcended and carried on beyond that through the legacy of her. And it's etched into the name, like the B, which you guys see right here. It's etched into her. It's etched in by what she's done and the impact that she had.
That's incredible. And I mean, what a way to honor her. And, as you said, she's left a legacy, and, that will never be taken away. Andy, I wanted to mention, I know, we'd spoken previously at great length about the work you're doing for the Indigenous communities there in Canada, and something we're very passionate about. I shared my grandmother was French Canadian Indian. And I know you're part of, I apologize if I pronounce it incorrectly, you're a proud member of the Muskeg Lake Cree Nation. Is that pronounced correctly?
Yeah, Muskeg Lake Cree Nation, yeah.
Got it right. Perfect. And I know you've spoken before, like I said, about the unique challenges the Indigenous communities face when it comes to dementia care specifically. Can you kind of help us unpack that and what those circumstances look like in Canada today?
Yeah, so we know that dementia care itself across Canada is bad. It's supposed to be getting a whole lot worse. Across Canada, we're expected to see a 200 and some % increase across Canada between now and 2050. Really, really not good. But where it gets even worse is in the First Nation community. So just a little bit of a contextual lesson for some of your audience if they're not aware. So in Canada, we have 3 protected groups that are classified as Indigenous under federal legislation. We've got First Nations, so individuals that have signed a treaty with the with the Commonwealth and the Crown. You have Métis, so generally individuals who have signed scripts, and then you have Inuit, and generally Inuit tend to have what's called like a modern day treaty, where a lot of the treaties, like Muskeg Lake and Treaty 6 was 1886, I believe it was like July to September 1886 that it was signed. So these things have been around for a long, long time. We have kind of these 3 protected groups that are under the Indigenous banner, and we see that the health determinants generally are a little different depending on the type, but we don't necessarily have the data to distinguish between does First Nations versus Métis, does Inuit have different dementia determinants. We don't know it to that minute level. So a lot of the time, as I'm going to talk about Indigenous, it's kind of talk about Indigenous as a whole with those 3 protected groups. So in 2006, less than 5% of the Indigenous population across Canada was over the age of 65. So less than 5% of Indigenous people across Canada were our elders. And in Indigenous community, elders are so important. They carry on the knowledge, they pass on knowledge, they say what's good. They are the guidance mechanism for the community, right? Before a big major decision gets made, elders are brought in to talk about it because they have the wisdom to make these decisions. But the crazy thing is that in 2006, less than 5% of our Indigenous population was that. By 2016, this rose to 7.3%. And by 2036, they're estimating that this is going to be over 15%. So this is really, really good. We're seeing Indigenous population is increasing. We're seeing that some of the health determinants are getting a little bit better, but there's still tons of problems, right? If we want to have a safe and secure and healthy Indigenous population, we need to make sure that our seniors and our elders are aging appropriately and we're taking care of them across the entire spectrum. So in Alberta specifically, dementia rates are 34% higher than within First Nation communities. So we see 34% more prevalence for dementia for First Nation folks than across Alberta. And interestingly, we see men are also more prevalent to have dementia in Indigenous communities than women, which is kind of against statistics everywhere else. Why? I have no idea, but it's an interesting statistic, right?
Right.
And Dr. Jennifer Walker and Dr. Lynn Croshaw argue that some of the colonial implications whether it's residential school, 60 swoop, whether the negative impact of anti-Indigenous bias in healthcare, whether it's the resident or the reservation system that Indigenous people were forced to live in, maybe whether it's disfranchisement, all these things lead to intergenerational trauma, which is likely a large contributing factor to those dementia diagnoses. Dr. Pamela Roach, who is an amazing medical researcher here in Alberta, she did some research in 2023 and found between 10 to 25% of practicing Alberta physicians have reported explicit anti-Indigenous bias. And that overall, across Alberta physicians have a moderate implicit anti-Indigenous bias. That's pretty wild.
Yeah. What's the logic or the reasoning? Is it blind? Is it subconscious? Or is it outright discrimination or bias?
Yeah, so the 10 to 25% is just outright discrimination. An example of that is there was an individual in Winnipeg, so out east of here in Alberta. His name is Brian Sinclair. And Brian Sinclair was left, actually back up, Brian Sinclair was a guy, he was in a wheelchair. He was, I think he was about 60 years old, and he was a double leg amputee, and he was in this wheelchair, and he had a kidney infection. And he went to the hospital in downtown Winnipeg to go and get looked at. So he wheeled himself in to get his thing looked at. He was left in the waiting room. It was something like 65, 70 hours unattended. And don't quote me number, it was something to that effect. And Brian Sinclair was there and nobody dealt with him. Everyone just kept putting aside, saying all these negative things towards him, that some people said he was homeless. Some people said all these other negative things, but no, the triage nurses ignored him. Everyone ignored him. And he ended up dying in that emergency room chair. And the investigation after said he died something like 3 or 4 hours prior to them checking on him again. And it wasn't even like the triage nurse was the one looking at him. It ended up being one of the patients that was sitting in the emergency room waiting. So there are these systematic barriers. And I mean, I've heard from community that sometimes that Indigenous individuals, if they need the support, they need to go, and they live on a reservation an hour or two away, they need to go and get the support, get the care. And so again, for context for the American folks, if you are a status First Nation individual, status Métis and Inuit all have different kind of rights through the government. And so status First Nation individuals have what's called non-insurable health benefits. So we all kind of probably heard that in Canada, we generally get free healthcare. So I go to hospital, I don't have to pay out of pocket. I can go to the doctor, Medicenter, whatever, get it free. Under NIHB, so non-insurable health benefits, I also get my prescriptions paid for. So if I need medication, if I need a walker, or if I need a mobility scooter, or if I need glasses or whatever the thing I need, that's covered. It's fully covered by the government under the treaty signings. But the problem, though, is that, and what I've heard from community is that that's great, that I will get funded and get the shuttle and stuff to go get my mental health supports. But what am I going to do with my kids? They're not allowed on the bus to come with me. I can't just leave them there. There's not a daycare for me to put them in. Where am I going to do with my kids? So I'm not going to go and leave my kids here, which is a problem. Right?
Are they First Nation, Andy? Just curious, because of you being their father, do they inherit the same rights as you?
This is where it gets very complicated.
Okay.
So not necessarily. So my kids are technically Métis, and so it's really complicated, but not necessarily, because it depends on who married who and what happened. So like in my family, my family went through what's called disenfranchisement, where historically there were a lot of mechanisms in place under the Treaty Act to go and remove the Indian. The objective of the Indian Act itself, which is the governing law that kind of spells what is and what isn't covered and what the rules, all these kind of things are. The objective was to completely remove the Indian out of the person, to integrate them into this Eurocentric society. And so my family went through what's called disenfranchisement. So a Indian woman from reserve married a non-Indigenous man, and that means that she loses all connection to her community. She's kind of told, it's time for you to leave, and you lose all relevant status and everything, and now you're fully integrated into the typical white settler society. And so that occurred. You saw the same sort of thing if a person, First Nations person, would go and join the military, they would lose it. If they became a doctor, they would lose it. If they became a lawyer, they would lose it. There's tons of historical examples of where they would lose it. And my family went through that. So for for multiple decades, my family didn't have it. My dad only got his status back in probably 2008.
Wow.
My dad got his status back. So before that, he had nothing. My grandmother had her status back before that. They found that it was unconstitutional to take my grandmother's status away. So yeah, my dad got his back in probably 2008. So I was a member of the Métis because my family technically still received a scrip. So I was a member of the Métis Nation. But then when in 2021-ish, Justin Trudeau changed the ruling a little bit to allow me to get my status, and then I had to withdraw from the Métis Nation. But yeah, you see, back to the question, is that my kids, because of that, are still members of the Métis Nation as opposed to status members because of what it is. And I'm what's called a C31 status, because there's a bunch of different criteria. Like instead of like blood quantum, which is what I know the American government really likes to use blood quantum as kind of the determinant. That's not really how it is here. It's the type of status that people have and who married what type of status. It gets very, very complicated. And the First Nation communities themselves, like, you can have all these benefits, but if you can't reasonably use them, what are you going to do about it? I know an interesting example, Lance, is like the mental health piece. Like if you have maybe early onset dementia or mild cognitive impairment or one of these, and you want to get some psychological support, what we see is that the majority of the mental health providers are non-Indigenous. And if you want to bill back to non-tribal health benefits for your mental health support, your choice is to use a non-Indigenous person or to go to someone that's in community. And if they charge you, you're out of pocket. A little bit of like my doctoral research I was working through and some of the framing stuff, I found that there were a lot of barriers for the Indigenous mental health providers, because in order to bill back to NIHB, you have to be like a registered social worker to be able to provide it, registered psychiatric nurse, registered psychologist, these sort of things. All that cost a lot of money, right? Certified counselor, I could do it in a certain context, but not other one. So like to be able to actually build back these systems, it was so cumbersome that a lot of people that you hear from that are like, I got into this because I wanted to support the mental health development of my community, weren't able to actually do it, which is wild that they get into it to support, but they can't spend the $20,000 plus to get certified to go from a provisional psychologist to a registered psychologist.
Right. Yeah. It's unfortunate. It's almost like it's designed to make you quit, right? It's designed so you can't reach that goal. I want to talk a little bit more about the culture and community. What role does culture and community play in delivering meaningful dementia care, and why is culturally appropriate care so important, especially for the Indigenous families? Because like you mentioned, you can go to a non-Indigenous, counselor, but if they don't appreciate and understand what you're coming from and your background and being Indigenous, they probably can't help you as meaningfully as somebody that is or has been in the Indigenous communities.
Yeah. I think I think it's important to say that blueBell wasn't created to only support Indigenous communities. So my grandmother had Alzheimer's. Her parents were from England. Um, so I mean, her dad was Arthur E. Wright, who had was a member of the Legislative Assembly and has a school named after him in Winnipeg. So they were a reasonably like immigrant from Europe family. That's my grandmother who had Alzheimer's was. My other grandmother was from, I was born in Marsden, Saskatchewan, so Muskeg Lake Cree Nation. And so she had this other life, right? You know, the two grandmas had radically opposed lived experiences. And so I built it for initially I built it for my grandmother, who again comes from this typically white lived experience, right? They were well-to-do, these kind of things. But I realized that there is more to this because my other grandmother, some of the things that were being done wouldn't have worked. Mm. And then I started thinking, what about, so my in-laws are from Nicaragua. What would it be for them? What would their experience be like? Because my mother-in-law, very proud Nicaraguan woman, like pretty much everyone in Central America is super proud of being from there. So what would it be like for her? If I told people caring for her to do these sort of things that are predicated on a Eurocentric epistemology or a Indigenous one, it won't go well. So I started kind of kicking around this idea, like how is the system set up now to really support them? And as I started going through it, I saw that every single system is based on this foundational Eurocentric model that says, this is what we have, and this is what we're going to offer you, which is actually kind of ironic because the America is really made on the melting pot, right? You come to America, this is what makes America great. You integrate into what you have, or you integrate into what America is. Here we have the mosaic. So everyone comes in, you do your own little thing, and all these different pieces shape and mold what Canada is. It's great we say those things, but in practice, right, that's not what we actually see in Canada, especially in the health sector. It's, and again, from an engineer looking from the outwards looking in, it's, this is what we have. This is what we can offer you. You like it? Great. If not, see you later.
Right.
And as I was kind of unpacking, I was like, okay, well, how do I fit? How do I support? And that's where kind of the important piece for me came in of, okay, so Alzheimer's and all these dementias really reconnect you oftentimes to past memories, past experiences. You may forget what you had for breakfast this morning, but you're going to remember your brother that you grew up with. My grandmother's case, she always would talk about Don, and Don was her brother. He was, I think, 7 years younger than her. And no matter what happened, he would call. A picture of Don would come up on her little digital picture frame. She knew who it was, what was going on. She connected with it, but she would forget the more recent things. So as all this kind of stuff started working through me, I thought, why do we not give the tools to the caregivers to understand that cultural and community piece so that they can connect to this person at a more fundamental level? Because that's really important. Right. And I don't think it's reasonable to assume that I hire some caregiver in and they have to be an expert on every single culture and community. That's just wild. I mean, look at South Asian or even Asian communities, right? Taiwan, Singapore, Thailand, China, Japan, Korea. I mean, there are so many of them. Vietnam, like they all have some similarities, but they're not all the same. So if you don't understand the nuance, you're applying a blanket approach, and it may work. It may work great, but it also may not. Right. They also may be going and saying, "Why are you doing this? What, I don't understand. What's the point of this thing?" So South American communities, a lot of times they don't when I've talked to a bunch of them from all places, they don't typically drink that much coffee, right? That's not a traditional drink. Instead, they drink mate. So if you would go and say, hey, let's make coffee together and talk about things while I drink coffee, they might be like someone from Chile, they might go, why? I don't like coffee. I don't drink coffee. Like, yeah, but you're Latino, and like my wife loves coffee, but that's what she does. She's from Nicaragua, and like that's what she connects to. But if we say everyone that's Latino likes coffee, they may be like, whoa, this doesn't make sense. They might cause more problems.
Sure.
And so I think for me, being able to give caregivers the supports that are culturally and community specific, I think are really, really important. So I think just backing up a bit. So like we have this tool called blueBell Connect. And my vision for it was the idea of let's give caregivers, whether family or hired, the ability to have the supports that they need when they need it on the fly. So it's 2:00 in the morning and grandma's riled up and she's having a tough time. I don't know what to do. I'm sleep deprived. I am tired. What do I do? How do I navigate this? Pull open your phone, go to blueBell Connect, and I get some sort of supports. Or let's say that it's, I don't know, 11:00 in the morning and you're hired to care for someone and you're like, I don't know how to do this thing. They have frontal temporal dementia. Maybe I don't really know exactly how that differs from Alzheimer's. I'm kind of used to just the blanket dementia term, so I don't know what that means. Maybe you don't, you're like, I need to do something. I was asked to do some activity with him, but I don't understand what I need to be doing. I'm just going to go and say, let's just color something, like let's do a puzzle. And then you see some behavioral mechanisms and change. Why is this happening? We're not necessarily doing the right approach. And I can't fault on you for it because everyone's impact is different, but that's kind of where we got into Connect was how do we build something that everyone who's going through dementia, a tool can be built to support them as they need it and develop as they need care so that caregivers can be supported, whether they are from Zambia, whether they are from Argentina, whether they are from India in a specific like English speaking Indian community, no matter where they're from, you can care for this person in a way that's clinically valid, personally specific, and culturally appropriate. And I think the culturally appropriate thing is an important piece because as you talk about culture, right, people want to be thought about and want to be valued in their culture. Again, my mother-in-law is a great example. Super proud Nicaraguan woman. If you go and say, and I've seen this talking to folks that are in some of these dementia day programs, and they go in, and again, I think these things are great. They do a good job, but they go in and say, you know what, everyone, we're going to do these like Tai Chi kind of activities. Absolutely not. My grandmother or my mother-in-law would not do it. Again, for context, she doesn't have dementia, but she's just an allegory for how I kind of process this.
Absolutely.
She would not do that.
It's not her thing.
No, but unfortunately, that's what we oftentimes are doing. We're saying this thing is good from this place, this thing is good from this place. Let's all bring it together, and everyone's gonna be happy because we're doing a little bit of me and a little bit of you.
Yeah.
Why don't we do it so it's all them when we're caring for them? Because that's what is important, and that's ultimately kind of what came up for me was the idea like let's build this tool so that no matter who the caregiver is,
right,
whether it's a family who typically doesn't understand the clinical difference between a frontal temporal, Lewy bodies, Alzheimer's, they don't typically understand the nuance. The hired caregivers who don't always and oftentimes understand the clinical piece, they don't understand the cultural piece, but they also oftentimes don't understand the personally specific piece. So what was the person's education growing up? What is their level of comprehension and reasoning? What is their physical ability? If we're going to say make this person do, I don't know, like Tai Chi, again, that's just an example here, but the person has body mechanic issues and they can't really move very well, It's not reasonable, right? And sometimes I see like, this is what we should do, but they can't move. We'll find a way to help them move it. I'm like, let's not do that. Let's find something that works within their ability now. Because I mean, if you would get my grandmother, and I love my grandmother, if she's gone, I still, as we know, like, but like if we were to go and say, hey, grandma, I know you have a hard time moving around, but let's start standing up and doing a bunch of stretches. That would not have gone over well, especially as her Alzheimer's was getting worse. To say, grandma, get up and do a bunch of stretches, like it would have caused some tension. So for us to like get into people's hands and get people to care for their loved one the way they need it is kind of a cool part, because in Edmonton here, where I live, we see over 90% of individuals are caring for their loved one with dementia at home. In Edmonton, last time I checked the number, it was last year sometime, and there was 1,132 institutionalized dementia beds in the Edmonton region for over 22,000 people living with dementia. The system is not equipped to support.
No, it's not.
And the system itself, if you go into one of those facilities, they try their best, but they're only given limited funding from the province, so they can only do so much on their own. So they're doing the best they can with what they got. But they're overworked. They're not able to provide the best level of care because they're overworked. They have too many people, understaffed. It's bad, you know? So they're trying their best. But what you see is that they're not giving the one-on-one care. They're having to bounce between this person, this person. Oftentimes it's so transactional. They come and go. So it doesn't help the person that needs to build this relationship with them. There's all these kind of problems. So families are, to a significant level, staying at home and being careful by the loved one. That's what happened to my grandmother. My family chose to never put her in a facility. Ironically enough, where my grandparents lived, in the same building as their seniors' apartments, was a dementia specific facility.
Okay.
It's literally a 3-minute walk through the building, but the choice was never to put her in there. We as a family explored that, but it was never the choice to do that because it made more sense to keep grandma in a community or a setting where she can be around my grandfather. We can have the care come in, and you know, some families don't have the luxury because they can't afford the private care, and especially I'm sure that's the case in the American context. But you know what? We're finding families are finding a way, especially in the. I know quite a few Hispanic families that have people going through dementia. They're wanting to keep them in because that's cultural. That's right. Yes. Same, especially in the African community. I know quite a few folks in the African community. Indigenous community, the same. You see a lot of these communities are like, yeah, we'll just care for them by community. We'll figure out how to do it. Don't know how we're going to do it, but we're going to figure it out. And what's interesting, I think, is that a lot of people, especially when they're starting out, don't realize that options exist.
No, they don't. You don't know what you don't know. 100%. Yeah,
and a lot of people are like, I'm going to go and rely on this one source. I will Google it, and that will get me where I need to go. Yes. I have this friend. Her name is Tammy Lautner, and she's here in Edmonton. And she has this company called Peace of Mind Consulting. And what she does is she's kind of this like navigator that helps seniors and their caregivers that like, where do we go? How do I know what I need to know? Because like you just said, I don't know what I don't know.
Right.
And I'm going to Google it, but that's great. But what about trying to figure out your wills? What about trying to figure out like who takes care of this? What about how do you navigate the money dynamics when you don't have the comprehension to do it and your loved ones are now having to try to figure out how to cover for you? Like, how do you figure these things out before? And I think that we're starting to get a point in the system, at least in Western Canada where I am, that we're aware of these dynamics, and we know we need help, we need support, and we know that we can't just keep relying on the system. So I was a high level athlete actually years ago, many moons ago, when I was like 18, and playing football. And now I kind of went away from it all, but I've taken up endurance sports since I did this.
Yeah.
And since I started taking up the blueBell mantle, not because I necessarily am like, yes, I want to go kill myself on these endurance things, but because I think that I can use it to show individuals that one, physical activity is important to decrease your dementia. And as I'm doing these things, bring awareness to that, as well as to go and bring awareness, like systems exist to support your level of dementia that aren't this box that says, this is all the systems we can give you. Other things exist. So there's this study from Lee in 2018 that said participation in high, which is a total of over 1 hour of physical activity over the course of 3 sessions per week, and a moderate, so a total of over 1 hour of activity over 2 sessions per week, will increase or will result in a decreased dementia risk compared to physical activity. So we're seeing significant impact by physical activity. And sedentary life is so much easier. I would rather be sitting on my couch having chips and watching a show. Would love it. But as a family that has dementia and other kind of mental health problems historically, like, how do I change that dynamic? And I think, so being able to do these endurance races, so I've done 3 triathlons. Now I did a marathon yesterday morning. I'm training for an Ironman 70.3 here coming up. So we're doing these sort of things, and I have blueBell and I've on it, and I've got talking about dementia and stuff on it. So as I'm running, so I can have biking. No, I'm swimming for obvious reasons, but as I'm doing these other things, I can have conversations with people, as maybe to like try and bring awareness, like the systems exist,
right?
And we're, by doing these physical activities, doesn't matter if you're placing first and getting a podium, or you're last but you finished it, right? It really doesn't matter. It's the process of doing these things are important to decrease that the prevalence of dementia. And I think that's where my passion right now is trying to show families there is a different way. And through my endurance stuff, I think it shows that, like, yeah, it is. This is one way. You guys are doing a good job of that. And if you have a loved one that isn't doing it, like, there are alternate supports out there. So I think that's an important piece. And then through the Connect lens, it's like giving families the tool on the fly that if any of your listeners, doesn't matter whether they're on north of the border or south of the border, I mean, it's available to support. Because I don't care whether you say you're north of the American border, South American border, or whatever country, like, dementia doesn't care.
Yeah, no discrimination there. That's for sure.
No.
I read something, Andy, a couple years ago, but it's always stuck with me, and it kind of ties into this. It was a little thing about dementia, and it says, our president, Ronald Reagan, as you may know, he developed Alzheimer's towards the end of his second term in office. And it said, even if the president of the United States can develop dementia, anybody can develop dementia. It doesn't matter who you are or what you are. And I think that's so true. And, what you're doing by just doing a tremendous job of raising awareness and, tying it back to blueBell in memory of your grandmother, but also as a result, trying to directly affect and benefit all of these other families it's phenomenal. That's why we were so glad to, have you on the show. I wanted to talk a little bit more about blueBell Connect because, I think it could be very revolutionary if it's not already. How are you and your team currently working to get blueBell Connect into the hands of families in these care teams, and what kind of responses have you been seeing?
Yeah, so blueBell Connect is it's pretty cool. It was a engineering challenge. It's one of those ones where, like, this is what I want to make. How do I make it? I have no idea. We're going to keep trying to figure it out. And it's kind of like the Walt Disney magic. You just keep trying and tinkering, and what the Imagineering folks do, or they just keep imagining what it could be and tinkering, and eventually you make it. And we figured out how to build an algorithm that can evaluate all this personal information, such as your mobility or education, religion, where you grew up, diagnosis, and a bunch of other factors to go and generate these recommendations for you. We actually have a provisional patent right now by the U.S. Patent and Trade Office for how we've built this algorithm. The patent does other things that are kind of future goals as well for it. But really, it's been cool, and families have been really receptive to the idea, because a lot of families are like, I've heard this from multiple people. They go, when I'm starting off, I don't know what I need. I don't know what I need to do. This gives me the opportunity to have a starting point,
Right.
having something to do. If you've been caring for your loved one for a decade and you do it all by yourself, Connect probably isn't the right tool for you because you've figured out your rhythm for it. But if you have people coming in, it might make sense that way. So Connect really has two distinct functions. First function is to be able to provide those recommendations. So activities, support techniques, or de-escalation techniques. So it kind of does that function. But the second function that I don't talk as much about to caregivers, because the healthcare folks tend to like it a lot more, and it's the idea of bridging caregiving islands, and that's kind of the metaphor that I use. It may be the same in the American side, but on the Canadian side, we've got, especially in Alberta, we have what's called Connect Care, so that all of our physicians' notes can all connect to each other, and specific other healthcare providers can all see your healthcare records. Everything's all connected, which is great. That's great. But if I hire a home care company, and there's what's called the client-directed invoicing program, which means that home care companies can bill back the government for some of their home care billing, but they can't connect to home care. So what they're doing here, the home care companies don't connect to what Connect Care is doing. And then what this home care company is doing doesn't always connect with this home care company is doing. But if you have a companion care company who's non-clinical but spend a lot of time supporting things like cleaning and tidying and making food and these kind of things, they're certainly not connected. So none of these people are talking.
Right.
So we have all these different islands. But then you got family coming in, and the family are talking to each other, but usually it's through one person. In my case, it was my aunt. My aunt was the one we were all communicating through. But nobody is talking. So everyone does what they think is best. But in reality, we're kind of doing this, all going apart. And I recognize, like, this is a problem. And I call that the caregiving islands. It's because we all are doing what we think is best, but we're all existing in our own little islands. And that causes a problem. So how do we bridge these caregiving islands? And that was kind of an interesting piece we integrated to Connect not too long ago, was the idea that these people need to be connected, need to work in unison for each other. So whether you're this home care company, caring for my grandmother, or this companion care company, you need to be aware of what things have been done prior to you, what things worked and what things didn't work, and then update the supports based on what works and what doesn't work. Because if you're doing this thing and it's causing a bunch of problems, the person after you is now dealing with it. So let's make sure that we're on a positive trajectory. The other thing I've noticed is that with care notes and care session logs, that's great, but they're 99% of the time useless for the average person. Really, they don't serve a ton of purpose for most people, because this prescription, this amount, this time, maybe a random novel, so it doesn't mean a lot. So how do we get the family and then the neurologist, in the case of dementia, on the right track? How do we understand that they understand what's actually going on? Because they're not going to see blah, blah, blah home care's notes. They just might see a random bullet pointer. This person said this, and then kind of hearsay thing happening.
Right.
So we built the ability so that all these care providers can write session log notes. Like, this is what happened. Shirley kept talking about not being able to figure out which bathroom she needed to use on, and it caused a problem. Something like that. And a one-off that doesn't do much, but if we have multiple companion care, home care, family members all logging in and providing these notes, at a macro level, there's really interesting longitudinal data there that says, hey, this is what we're seeing across the trajectory. And with that longitudinal information that we're seeing between all these people over this time, that can be fed back into your physician, your neurologist, whoever it is, to say, this is what we're seeing, this was happening around it, this is how we adjusted, this was their response. And then we can make evidence-based decisions. Because at least what I've noticed and what I learned was that it was all recorded on a phone and notes app, which is fine. But one, you're assuming that the person providing those notes and the person giving the information understands the clinical implications of it. You're also assuming that they wrote it down correctly. You're also assuming that they understand all the pieces that were happening around it. What were the external stimuli going on? All these kind of things, which there's a lot of assumptions here, Lance, which, yeah. I mean, you know what they say about assumptions, right? And
I do.
And yes. It doesn't always work. So how do we get the physicians to understand the big picture so they can make the best decisions? Because if we're relying on them as a physician to make the right decisions, let's give them the best information. And physicians are very, very good at evidence-based decisions making, right? Objectively, they do it for years, right? Them and PhD folks, really good at evidence-based decisions.
Yeah.
The rest of us, kind of good. Kind of learning, right? But they're really good at it. So how do we give them the stuff that they need to do it? And that's what the other part of Connect was setting up our physicians and our publicly funded healthcare system to be able to make the right decisions.
Yeah. Well, I know you said like the rest of us, but pretty soon you're not going to be like the rest of us, Andy. You're also pursuing your doctorate now. Tell us a little bit about your research and what you're trying to accomplish with it.
Yeah. So doctorates, I would say, are not a fun educational journey. I don't think anyone pursues a doctorate going to say this is going to be fun. Master's was a lot of fun. Undergrad, a lot of fun. Doctorate, not a lot of fun. It's a lonely journey, but you know what? I got into it because what I want to study is something that I think needed to be studied, and I am in a unique position to be able to study. So I'm doing my doctorate at University of Calgary right now. So my research is specifically looking at what leads Indigenous entrepreneurs to new venture creation in the healthcare sector. This came up because I've been asked more times than I can count to go and attend an event and talk about Indigenous entrepreneurs in health. And then I get there, I'm like, hey, sure, I'll show up. And I'm the only one there. And it's like, you are the guy to talk about it. Like, I don't want to be the guy. Like, bring other people here and talk. I understand why that happens, though, because there are so few of us. So statistics in Canada say 11% of entrepreneurs should open their venture in health. We see less than 5% of Indigenous entrepreneurs opening their ventures in health. And there are factors such as ones we've already talked about that lead to it. But then you also have factors of it costs more money and more it's more complicated to create a health company. There's way more barriers. Like there's issues with it. So how do we truly understand what leads creation so we can, on the flip side, work to navigate those barriers to increase participation for entrepreneurial individuals in healthcare sector? One thing I'm really interested in is the role of data sovereignty and data governance in the new venture creation process. So like, who owns the data? How do we ensure that the right Indigenous hands get the data so they can make the right decisions? Because all too often the conversation is, yes, we want you to have it, but no, we don't know how to give it to you. We don't know how to give it to Indigenous communities. We think there's value in Indigenous communities having this data, but it doesn't always work the way it needs to. So how do we come up with and continue to adapt the process to be right? So there's a thing in Canada, actually globally, there's what's called the CARE principles, and it is how do we navigate Indigenous health data. At Canadian level, First Nations Governance Information Center, FNIGC, it stands for something like that. And they create this principle called OCAP. So when you're dealing with Indigenous individuals and anytime you do research, you need to consider who owns the data, who has control of the data, who has access to the data, and how are you protecting the data. And those are things we need to consider when working through Indigenous research. And what I've found was oftentimes people that are the arbiters of that data are not actually Indigenous themselves. And so they say you can't, and I've got examples from large health agencies in Canada, and not just me, but other like PhD trained in medical fields and stuff. And they go, okay, well, I'm Indigenous. I would like to access data to some research on it. No, you can't have it. Why can't I have it? Because you can't. But I should be able to have it for this reason. The community signed off on it. But the arbiters of people saying you can't have it aren't Indigenous themselves. They're following OCAP principles, which was created for a reason. But they're not the true person who should be determining it. They're just saying this is what it says, and this is how we're going to hold firm to it without recognizing there's some subjectivity to it. So for the folks here that don't know about it, the principles, for example, and the reason that we have these principles is because Indigenous people were subjugated to various historical traumas through research. So Hitler and his team, for example, determined that the Nazis should be put on these encampments because they saw the success of Indian reservations in Canada and the US. That was what the Nazi party went and said, that's a good idea, because he saw the success. And I got air quotes for the listeners here.
Sure. Yeah.
Of that. So I'm sure you have a version of it, but the food guide that tells you how you need to have whatever, half a plate of fruits and veggies and whatever, it's a quarter of meat and whatever else it is, right? In Canada, it's Canada Food Guide. I'm sure there's an American version of it. There you go, food pyramid. So in Canada, it was developed through residential schools. And so for residential schools, for the people who don't know, was children would be ripped off of community, literally. There's tons of pictures of it. The Royal Canadian Mounted Police would show up with members of the government, and they would take the children out of their home, send them to some other city far away from their community. And if they spoke their language, they'd be beaten. Kids would try and run away. Many of them would die. There's all these like negative problems with residential schools. I don't have time to go over, but the Canada Food Guide was developed by them testing the different nutrients. So what if we don't give them protein? What if we don't give them fiber? What if we don't give them whatever nutrients? That's how they tested what would work best. They use residential schools, Canadian government, as a way to test what should nutrients be on people.
What time period, Andy?
20s, I believe.
Okay.
Yeah. The last residential school closed in like 1990, roughly. The late 90s, yeah. Yeah, and then the Kamloops, so Western Canada, so in BC, a handful of years ago, they found like residential school mass grave site. There was hundreds of kids' bodies that were found there. There was tons of them. Like in Edmonton here, there's one like 15 minutes from my house where it used to be. It was terrible. It was ran by a lot of the time. It was ran by the Catholic Church, ran the residential schools. It's bad. There was a fella who was a professor at UBC, and he went and with consent, he got the blood data from this specific Indigenous community, a bunch of their blood, and he was looking at arthritis. So he went and they consented to have their blood used for this arthritis research. The problem, though, was that this fellow then went and used it for the rest of his career. He used that same data set outside of what they consented to, and he ended up going to I think it was Oxford. He ended up going and becoming a professor at Oxford, and then he went to, I think he retired at BYU, I think is where he retired. But he traveled all over the world to go and do this research, and he ended up using that Indigenous data that was signed off for one time to use to study arthritis in a specific community. He ended up using it to like test on how connected the Indigenous DNA is between Canadian Indigenous versus Asian people. And he did all these kind of things that were very ethically bad.
Wow.
And so we have all these things that have happened.
So let me ask, we had similar things done here in the States, obviously. And, there are some communities that still have a very strong memory of those things, maybe not necessarily happening to them, but to their cultural groups. And so they have a fear and distrust of the healthcare community and a fear and a distrust of the government. How is the Indigenous population in Canada? Are they still accepting and trusting of healthcare and the government after these atrocities? Or, is it a little bit, what's the after effects of this? Because it's got to be traumatic.
Oh, yeah. So it's funny, not haha funny, but kind of like ironically funny that the communities themselves, they recognize the support, they need the support, but they also don't want the support. I was actually in Indigenous community a couple of weeks ago with a health director of one of the communities, and I was talking to them about this, and their biggest thing they're going through right now is how do we show community that we need to give this information. Like generally censuses and surveys and stuff are not answered because the data assumes that it's just a person with no story, no experience, and it can be used inappropriately. So like they don't recognize it, so they don't want to do it because it could be used egregiously.
Right.
And they're trying to go and change that stigma and change the narrative. Like, yeah, we need to start engaging with these things because this is how we can support ourselves. So I think that some folks themselves are really understanding the value of it, and some folks themselves are trying to make change. But I would say, from my experience with talking to people, there's a lot of hesitation. So there's one specific individual in particular. He is a First Nations guy here in Western Canada, and he doesn't trust the system for obvious reasons. He's an elder, doesn't trust the system. So there's been some times where he has medical questions. Again, not a medical doctor, right? And he will call me for questions. And I will bring him in the loop with other people. And he wants me to stay on the line. So I just put on a speakerphone and I continue doing it. I'm doing well. Him and these other people are conversing.
Okay.
Just because he doesn't trust the system, but he trusts me. And I think that's the thing we have to navigate, especially with these communities, is that we can't go in and say, this is how we're going to solve your problems. It's got to be by community, for community. And part of OCAP is the idea of community involvement in that decision-making of is this actually what community wants?
Right.
But in the case of one organization, which I'm not going to name, they said, OCAP says, you guys can't have this data to the specific researcher. But the people that were determining it were not Indigenous. They just said you can't have it, but they didn't understand why you couldn't have it. The people who determined was a guy from Italy and a girl from China that worked for this specific federal agency. And they said, OCAP says you can't have it to this researcher I know. But OCAP wasn't designed for them to be the arbiter. It was, you follow these framework, you have this process in place, you have these things, you have the credentials, all this kind of stuff, you should be able to access it. But it doesn't go back to the final piece, which I argue is arguably the most important one of Indigenous people should have the say of the final say, not these other people, because that re-perpetuates a colonial narrative.
Right.
And I think it's so important for us to really consider that there are alternative ways to going about these things.
Absolutely. I just want to wrap up, Andy, and again, thank you for your time and what you're doing there in Canada, especially for the Indigenous population, but also through blueBell Village and blueBell Connect. Where can people go to, and we're going to have everything in the show notes, but for people that might be listening right now, we're going to put it up on the screen for our viewers. Where would you like people to go to connect with blueBell Connect and blueBell Village?
So there's a couple ways you can email info@bluebellconnect.ca or info@bluebellvillage.ca, whichever, if you want to reach out and get more information. We also have a podcast called the Dementia Collective, where we speak with individuals living with dementia. So we had Jim Mann, who is arguably the leading voice of people living with dementia in Canada. He was on the podcast recently. He was diagnosed with Alzheimer's 18 years ago. And he's still living, and he still commutes and gets himself around. Takes the bus, but he gets around, and he served on the Alzheimer's Society board for 2 terms, and he still gives public speeches and stuff. Like he's a testament of what you're still capable of after. And then we got some researchers on. We've got support organizations. We always have people on. So if people want to come check out the Dementia Collective, it's our podcast. You can also look at us on LinkedIn. Andrew Karesa is my LinkedIn. Feel free to connect with me there if you need anything. But yeah, just check out the website and reach out if you guys have any questions. I'm an open book and glad to support.
Absolutely. And so one final question for you. We're going to stay in contact because we want to help support you in the tremendous work you're doing. But if, let's say, we didn't connect and we ran into each other 5 years from now, where's blueBell Connect and the work you're doing at?
That's hard to say. If you would ask me last year, am I going to launch a podcast, for example? Never would have wanted to launch a podcast. Never would have thought I would have. But you know what? We are here. So it's hard to say because I never wanted to be in health. I never wanted to do anything. I just did it because that was what the need was. And I felt God leading me to do these kind of things. And so that's ultimately how we got here. So where I'll be 5 years, the only thing I can say is I hope I am done my doctorate. That's the only thing I can say at that point. Otherwise, who knows what we're going to be doing. I would like to see the patent for Connect and the technology in the back end be fully done and approved, because apparently the patent trade office takes years to do anything because bureaucracy. So hopefully that gets through. But I just hope to see lots of families using it and supporting and keeping their loved one close and in community where they could be cared for appropriately the way that they need. That's my vision.
Well, perfect. And any way we can help you guys support that vision and work, Andy, we're here for you. Again, Andy Karesa, the president and CEO of blueBell Village, thank you so much. And future PhD, it won't be 5 years, Andy.
Hopefully soon.
Okay, good to see you.
Thanks, lads. Appreciate it.
Thank you for joining us today here at All Home Care Matters. All Home Care Matters is here to help families as they navigate these long-term care issues. We invite you to visit us at allhomecarematters.com, where there's a private, secure, fillable form where you can give us feedback, show ideas, or if you have questions. Every form is read and responded to. And remember, you can listen to the show on any of your favorite podcast streaming platforms, or watch the show on our official YouTube channel. Just make sure that you hit that subscribe button so that you never miss an episode. We'd also like to say thank you again to Andrew Karesa for joining us today. We look forward to seeing you again here at All Home Care Matters.
Thank you for joining us today. We look forward to you joining us again on another episode of All Home Care Matters. To learn more about the show and to connect with us, visit us at allhomecarematters.com.